Welcome to Roadmap to Residency. Hello everyone, I am Viras. Welcome to our Club 250 Maths Micro Sessions. We will be running through some questions with you guys to help you on your journey to a 250. This is a part 1 of the topic Neurological Emergency and Strokes. So here we have, based on these findings, this patient's cerebral injury most likely occurred approximately how long ago? So an 82-year-old man is found unresponsive by his neighbor. The patient lives alone in his suburban home. When the neighbor went to check on him, the patient was on the floor and not answering any questions. His medical history is unknown. On arrival of the emergency medical services, the patient is obtunded and responses only to pain stimuli. Supportive measures are begun, including endotracheal intubation, but the patient dies en route to the hospital. Autopsy reveals extensive atherosclerotic disease involving the coronary and internal carotid arteries. Histopathologic examination of the brain in the right middle cerebral artery territory, neurons with intensely eosinophilic cytoplasm and nuclear fragmentation. Based on these findings, this patient's cerebral injury most likely occurred approximately how long ago? Less than 24 hours, 12 to 24 hours, 1 to 2 weeks, 2 months, or 2 years. So this patient probably may be suffering from the ischemic stroke. So the microscopic changes are in the first 12 to 24 hours, you can see the red neurons, which is indicated by eosinophilic cytoplasm, pycnotic nuclei, and loss of nasal substance. 24 to 72 hours, you can see neutrophilic infiltration. In 3 to 7 days, you can see macrophage, microglia infiltration, and phagocytosis begins. 1 to 2 weeks, you can see reactive gliosis and vascular proliferation around the necrotic area. And more than 2 weeks, you can see glial scar formation. Remember that the liquefactive necrosis, which is extensively seen in brain, occurs at 1 week to 1 month. And the cystic area surrounded by the dense glial fibers is in the period of more than 1 month. So now if you just pause the video and look at the question and answer, what may be the following option choice? So the patient was found unconscious in rapid hemodynamic decline an unknown amount of time after an inciting cardiovascular event. Now the autopsy demonstrates histopathologic evidence of ischemic stroke caused by widespread atherosclerosis, sustained interruption in the blood circulation to branches of the internal carotid arteries. Midcerebral artery can lead to tissue hypoxia and irreversible cellular injury with characteristic macroscopic and macroscopic changes. The specific findings vary with time, but follow a predictable course. Red neurons are typically seen 12 to 24 hours after irreversible ischemic injury and are characterized by intense eosinophilic staining of the cytoplasm due to dissolution of nasal bodies. Basophilic granules consisting of rough endoplasmic reticulum and ribosomes. The nuclei also become pycnotic, example shrunken and deeply basophilic, and undergo fragmentation, that is karyorrhexis. After about a day, the tissue damage promotes neutrophilic infiltration, followed by macrophage and microglial recruitment a few days later. Now, talking about the different types of stroke, the ischemic stroke, according to the area where the stroke lies or the circulatory uh, pathology. Okay. Now, if the stroke is involving the anterior cerebral artery, then the area of lesion is the motor and sensory cortices of the brain, in causing the area in the loss of function in the lower limb. The symptoms may be contralateral paralysis and sensory loss and urinary incontinence. If the area involves the middle cerebral artery, then there may be a constellation of symptoms. So the motor and sensory cortices may affect the upper limb and face. If the temporal lobe is also involved, it can affect the Wernicke's area, and frontal lobe may cause effects to the Broca's area. The contralateral paralysis and sensory loss may be seen in the lower face and upper limb. The aphasia, if is in dominant, usually left hemisphere. Hemi-neglect if the lesions affects the non-dominant or the usually right hemisphere. So dominant means that if you are right-handed, your dominant hemisphere is the left side, okay, left hemisphere, okay, in 90% or in more than 90%. And even if you are left-sided, the dominant area again becomes left-sided, okay, and only in 10% it is right-sided. The Wernicke's aphasia is associated. Now, if the question wants you to go in the right-sided dominant area, then it may give you the hint that the patient, it may clearly mention that the patient is having right dominant circulation function. Wernicke's aphasia is associated with right upper quadrant, while superior quadrant visual field due to the temporal lobe involvement. The lenticular striatal artery is when the lesion is in the internal capsule of the striatum, which can cause contralateral paralysis, absence of cortical signs. Pure motor stroke is the most common location of lacunar infarcts are due to macroatheroma and hyaline arteriosclerosis secondary to unmanaged hypertension. Now, talking about the posterior circulatory strokes like posterior cerebral artery, basilar artery, and anterior inferior cerebellar artery. So, posterior cerebral artery supplies the occipital lobe. And if there is stroke involving this area, we can see contralateral hemianopia with macular sparing. We have discussed this in the visual pathway of the previous videos. Alexia without agraphia and prosopagnosia, okay, if it is in the non-dominant hemisphere. Now, the basilar artery may supply the pons, medulla, lower midbrain, okay, and cortex spinal and corticobulbar tracts and ocular cranial nerve nuclei. Now, if reticular activation system is spared, consciousness is preserved. Okay, if not, then consciousness may be disturbed. The patient may go into coma. Quadriplegia, which is the loss of quadriplegia and loss of voluntary facial uh, uh, except blinking, mouth and tongue movements. There may be loss of horizontal but not vertical eye movements. Now, if it involves the anterior inferior cerebellar artery, it may involve the number of nuclei. But the thing with anterior inferior cerebellar artery is that you may see paralysis of face, okay? And the question may hint you about that is decreased lacrimation, salivation, and taste from the anterior two-thirds of the tongue. The patient may also involve, if the patient also has a vomiting vertigo or nystagmus, okay, and then you can think about the anterior inferior cerebral artery. So what is important is the lateral pontine syndrome. Also, if there is a Horner syndrome or a sensory neural deafnesses, then you can think that the person is having defect in the anterior inferior cerebellar artery. Now, another areas could be posterior inferior and anterior spinal artery. Now, if the posterior inferior cerebral artery is involved, then the question will be typical about the dysphagia and hoarseness. Okay, dysphagia, hoarseness, hiccups. Okay, and that is how you understand that the patient is having pica. Now, pica is in strokes. Now, talking about the anterior spinal artery. Now, it is a typical spinal cord sort of a syndrome. Okay, now you can see the question framed as only paralysis of the upper or lower limbs or both. Okay, so not so hard and fast thing in the interspinal artery. Also, the medial medullary syndrome is called by in fact of the paramedial branches of the ASA and the vertebral artery. Now let's talk about one more question here. So this patient's condition is most likely caused by which of the following? A 58-year-old man comes to the emergency department due to a sudden right-sided weakness. He has no sensory loss, problems with speaking, swallowing, or difficulty with balance. The patient was previously told that he has elevated blood pressure, but he does not routinely follow up with his physician. He takes no medications. Examination shows intact cranial nerves and sensory function. The patient has a 3/5 muscle strength on the right side. Initial CT scan without contrast reveals no abnormalities. And 4 weeks later, the repeat brain imaging shows a 9 mm fluid-filled cavitary lesion in the left internal capsule. Now, this patient's condition is most likely caused by which of the following: cardiac embolism, carotid artery atherosclerosis, hypertensive arteriolar sclerosis, hypertensive encephalopathy or hypoxic encephalopathy or sacral aneurysm. Now, this patient has pure motor hemiparesis and a small capillary lesion in the internal capsule, characteristic of a lacunar infarct. Now, this type of stroke affects the small penetrating arterioles that supply the deep brain structures and subcortical white matter. Lacunar infarcts are primarily associated with chronic hypertension, which promotes lipohyalurosis, microadherema formation, and hardening or thickening of the basal wall. Now, this leads to the progressive narrowing of the arteriolar lumen and predisposes to thrombotic basal occlusion, which causes characteristic clinical syndromes. Now, depending upon on the portion of the brain affected, the posterior limb of the internal capsule and basal pons, the pure motor hemiparesis or ataxia hemiplegia syndrome can occur. In the xeno or anterior limb of the internal capsule, dysarthria, clumsy hand syndrome can occur. Or if it is in the ventroposterolateral thalamus, then the person may only suffer from the pure sensory stroke. Okay, and these are the routes supplied by the different specific branches of the artery, and these are the symptoms that you may be encountering in the question. Now, whenever you encounter a stroke style question, remember stroke style question needs practice. Okay, so keep on practicing stroke style questions from different resources. You will be good to go. Thank you for watching.